Hey everyone, and welcome to this explainer. I am so pumped you're tuning in today because we are ditching the fluff and jumping straight into a high-yield boot camp on essential cardiac pharmacology. If you're prepping for the NCLEX or your nursing pharm exams, you already know that heart medications are like this massive, interconnected puzzle. Well, our goal today is to give you a highly structured, rapid-fire breakdown of exactly what you need to know to succeed. So let's get ready to master the heart.
All right, let's just dive right into our syllabus. We're going to conquer 4 major drug categories today, step by step: antihypertensives, antiarrhythmics, heart failure meds, and finally, antianginals.
Let's kick things off with Section 1, antihypertensives, basically lowering the pressure. So let's directly compare two absolute heavy hitters you'll see all the time: ACE inhibitors and ARBs. ACE inhibitors, which almost always end in that pril suffix, your lisinopril or captopril, well, they work by blocking the conversion of angiotensin 1 into angiotensin 2, which is a really powerful vasoconstrictor. But here's the absolute NCLEX gold you need to remember. They can cause this classic, super annoying dry cough, and that's due to bradykinin buildup. Even more dangerously, they can cause angioedema, a severe vascular reaction. Now, if that cough is just too bothersome for the patient, we typically switch them over to ARBs. These are your sartan drugs, like losartan. They totally bypass that cough issue by blocking the angiotensin receptors directly. Oh, and for both of these, you absolutely must monitor serum potassium because hyperkalemia is a very real risk.
Next up on the docket, we've got calcium channel blockers, things like amlodipine, diltiazem, and verapamil. These are basically peripheral vasodilators, meaning they just relax the smooth muscle in the blood vessels. On the flip side, we have beta blockers, which you can easily spot by that lol suffix. These guys decrease heart rate, conduction, and contractility. But listen up, because here is a massive NCLEX alert. Seriously, underline this in your brain. You have got to avoid non-selective beta blockers in patients with asthma or COPD. Why? Because those non-selective ones also block beta-2 receptors in the lungs, which literally leads to bronchoconstriction and airway resistance. So always assess respiratory history before handing out a beta blocker. All right, time to test that active recall. I'm going to read the question, give you a quick beat to think, and then reveal the answer. Number 1. True or false, ACE inhibitors commonly cause a dry, non-productive cough? Moving right along to Section 2, antiarrhythmics, controlling the rhythm. Now, when we're dealing with these specific meds, we don't just guess. We rely heavily on the Vaughan Williams classification system. Basically, it's just a really neat way to categorize all these complex rhythm drugs based on exactly how they mess with the electrophysiology of cardiac cells during an action potential. So this system actually breaks down into 4 main classes. Class 1 covers your membrane-stabilizing sodium channel blockers. Class 2 relies on our old friends, the beta blockers. Class 3 drugs like amiodarone prolong the action potential. And Class 4 utilizes those calcium channel blockers we just talked about. But don't sleep on that other category. It holds some heavy hitters that just don't fit perfectly into the main 4. We're talking drugs like adenosine, which literally resets rhythms incredibly fast, and digoxin, a classic cardiac glycoside. Actually, speaking of digoxin, you absolutely have to memorize these clinical pearls for your exams. Digoxin has an incredibly narrow therapeutic window. We're talking normally targeted between just 0.5 and 1 nanograms per milliliter. Because that effective dose is dangerously close to the toxic dose, toxicity is a huge life-threatening risk. If your patient mentions seeing yellow-green halos around lights, or they feel dizzy, or if their pulse absolutely plummets into severe bradycardia, you're looking at classic digoxin toxicity. This is why, before you ever give digoxin, you must auscultate the apical pulse for 1 full minute. If it's below 60 beats per minute, hold the dose and call the provider immediately. And just so you know, if toxicity does happen, the antidote is digoxin immunifab.
Okay, time for another rapid-fire review to lock in those antiarrhythmic facts. Question 1. True or false, the Vaughan Williams system classifies drugs based on their electrophysiological effects? That is true. Question 2. What is a key visual symptom of digoxin toxicity? You're keeping an eye out for those infamous yellow-green halos or blurred vision. Question 3. True or false, you only need to check the radial pulse for 30 seconds before giving digoxin? No way, that's false. You have got to check the apical pulse for 1 full minute. All right, on to Section 3, heart failure meds, boosting pumping efficiency.
Before we get into the actual drugs, we really need to define three absolutely critical terms. Knowing the difference between these is literally foundational for using pharmacology. So first up, inotropic. This refers to the force of the contraction. So a positive inotrope makes the heart squeeze harder. Then there's chronotropic, which affects the heart rate itself, meaning a negative chronotrope slows the heart down. And finally, dromotropic, which affects the actual conduction speed of electrical impulses traveling through the heart's nodes.
So, when we apply those concepts to modern heart failure treatment, it requires a very specific stepwise approach. Now, digoxin, which is a positive inotrope, well, it used to be the immediate go-to, but modern guidelines have completely shifted. Step 1 now is to actually protect the heart from adverse remodeling, starting with ACE inhibitors or ARBs alongside specific beta blockers. Then, step 2 focuses on giving the patient symptom relief from all that fluid overload, usually by using loop diuretics like furosemide. It's really only in step 3, when we need extra symptom management for the more severe stages, that we finally add digoxin into the mix.
Let's take a quick pause and make sure those heart failure concepts really stuck. First question, what term describes a drug that increases the force of myochondrial contraction? Yep, that would be a positive inotrope. Next up, true or false? Diuretics like furosemide are used in heart failure to reduce fluid overload. True, they help the kidneys flush out that excess sodium and water. And finally, true or false? Digoxin is currently the very first drug prescribed for new heart failure. False. As we just saw, ACE inhibitors and beta blockers are the modern first-line defense.
Almost at the finish line. Section 4. Anti-anginals, balancing oxygen supply and demand. So sublingual nitroglycerin is basically the undisputed gold standard for acute angina. The key thing here is its onset of action. It acts incredibly rapidly, kicking in within just 2 to 3 minutes. And the reason for that is the area under the tongue is supervascular, so the drug is absorbed directly into the bloodstream. This means it completely bypasses the liver's first-pass effect entirely, getting that rapid relief right where it needs to go. Now, there are some massive high-yield takeaways regarding nitroglycerin rules for your actual practice. Because this drug causes significant systemic vasodilation, your patient is very likely going to experience a pounding headache and a pretty potentially dangerous drop in blood pressure. So always have the patient sit or lie down before they take it. Storage is super critical too. It has to be kept in its original amber-colored glass container because heat, light, and moisture will totally destroy it. You also need to educate your patients that the bottle is only potent for 3 to 6 months. A good trick is telling them they should feel a slight burning or stinging under their tongue. That means the pill is still active. Oh, and remember the current emergency guidelines? If their chest pain isn't relieved 5 minutes after taking just one single sublingual dose, they need to call 911 immediately. Let's wrap up our boot camp quizzing with 3 final questions on anti-anginals, just to make sure you're totally exam ready. Question 1. True or false, sublingual nitroglycerin should be stored in a clear plastic pill organizer? Absolutely false. It needs that original amber glass container, no exceptions. Question 2. What are 2 major side effects of nitroglycerin? You're looking for a severe headache and hypotension. And our very last question, true or false? Nitroglycerin relieves angina by dilating blood vessels and decreasing cardiac workload. That is true. It decreases both preload and afterload.
Wow, you have officially conquered the cardiac boot camp in this explainer. We've navigated our way through antihypertensives, arrhythmias, heart failure, and angina. But remember, the human body is a deeply connected machine. So I want to leave you with this. How might these profound blood pressure changes and fluid shifts impact the renal system? Because when you're sitting there staring down those complex multi-system case studies on your exam, that is exactly how you need to be thinking. Keep studying, keep connecting those dots, and I will see you in the next explainer.